Hello, my name is Carlos. I'm a certified critical care registered nurse, and I'm here to talk to you about a topic that is caused a lot of controversy in the last 10 years, and it also has given the heebie-jeebies to a lot of nurses that are pursuing their CCRN certification, and that is advanced hemodynamics. So I've sat through a ton of classes that included air transport, ground transport, critical care transport. In every one of these classes, there was always hemodynamics. And many times I went into the class and I got out of the class and I was just as confused as I was going in. So throughout the years, I developed this little tool that has helped me identify the issues with the hemodynamics. And it's just, hemodynamics are great when you know how to use them, but if you don't really understand them, then you can also put the patient at risk if you don't really understand what you're looking at. So this video is just like a little introduction to help out some nurses that I know try to apply this, because the point is not only to know how to approach the questions that you have in a CCRN test, but how to apply this to your everyday clinical practice. So we're going to start from the beginning. Hemodynamics started with the creation of the pulmonary artery catheter in 1970 by Dr. Swan and Dr. Gans. After the creation of this catheter, we were able to obtain pressures, real-time pressures from the inside of the heart. These numbers we use for either to drive our treatment, or we can use them as a diagnostic tool. Okay, and it's very impressive all the changes that have happened since the creation of the first Swan's catheter. However, though, there was a study published by Connors et al. In 1996, where he really shows that the utilization of these type of catheters don't really affect the patient's prognosis, and in fact, they increase mortality. So there's a lot of ICUs that you don't really see these devices being used. In fact, in my experience, they are mainly being used in cardiothoracic units where real-time cardiac output or cardiac index need to be evaluated. However, though, in the medical ICU where I work, you don't really see this. I think I saw maybe one or two in the last 5 years or 3 years. So, in order to start with this, to get a really good grasp of what hemodynamics are, we kind of need to know how the heart works. The heart is awesome, it's magnificent, it has a ton of valves and things that we need to understand in order for us to really get a grasp of hemodynamics. So, like in anything you do, there are things that you have to absolutely just remember. I don't like using the term memorization, but unfortunately you have to. Now, I can tell you, and I will try to demonstrate some ways to help you to make correlations, which is what we are all about, correlations. I hate memorizing things. And at the end of the day, you will have a tool. I have it in the back of my card. I always have all the pressures in the back of my ID card. So I have all the numbers, all the pressures, and or I know where to get them from. You will really only need to memorize everything for your CCRN. But again, so let's get going here. So one of the first things I want to talk about is blood pressure. Okay, everything we do in the heart, it's driven by pressure, and we can measure that pressure externally, non-invasively, or invasively. So blood pressure is the product of cardiac output and systemic vascular resistance. Understanding systemic vascular resistance becomes very important, especially when you work in a unit that has vasoactive medication, because this is what we are increasing when we are using pressors such as phenylephrine, and I'll talk a little bit about those. Cardiac output, going back to our early nursing stages, is the product of heart rate plus stroke volume. Now, cardiac output is what we usually change when we are in a stressed situation, when our body's trying to compensate. We change either cardiac output, or we change either stroke volume or heart rate. So heart rate is always affected by the effect of catecholamines, epinephrine, adrenaline.
Your attention, please. Visiting
And,
hours will be ending at 9 p.m.
and those are the visiting hours. So stroke volume will be affected.
Will resume at 9 a.m. tomorrow. We appreciate your understanding.
So stroke volume will also be affected by the sympathetic and parasympathetic system. Okay, so this formula very important that we know it, because sometimes the changes that we make here will affect the cardiac output. So when we are talking about hemodynamics, vasoactive medication, inotropes, it's not a one size fits all. You have to know the patient. So I'm going to start all this presentation with a little case study. So I'm walking into my shift, and I have this 87-year-old female, intubated, and the settings on the vent don't really matter right now. But she was receiving phenylephrine, we call it NEO, running at 160 mics per minute. And the CVP was 20. The systolic blood pressure was 100. The diastolic blood pressure was 48. The mean arterial pressure was barely touching 60, barely touching 65. And the heart rate of the patient was in the 120s. No urine output. And according to the report that I got, the urine output had been decreasing in the last 4 hours. When I saw this presentation, I did a quick physical assessment on the lady, and she had huge JVD. So she was positive for JVD, right? Most of the time we look at JVD and we associate JVD with an overload, fluid overload situation. But anyway, we're gonna come back to this. So when we talk about hemodynamics, the CVP was 20. The right ventricular pressure was 18/8. The 38/8. The pulmonary arterial pressure was also 38/25. And the pulmonary arterial pressure, the PaOP, which is also wedge pressure and diastolic left ventricular pressure. So we're gonna call it PaOP because it's easier for me to say, bottom line. So this one was 18. The cardiac index of this patient was 108. So this is a ton of numbers. And really getting the whole picture of this it's not easy. This is not for novice nurses, and even for experienced nurses, it could take us a minute to get to the bottom of this situation, okay? So what I'm gonna do, I'm gonna write these values here in one corner. We'll talk about the hemodynamics, we'll talk about the numbers, we'll talk about all the measurements, and then we'll come back and look at it. I'll tell you what I did, and hopefully by that time, you will be able to figure out why I got there. So, which by the way, all my drawings suck, but you just gotta bear with me here. Cardiac index, it was 1.8, and systemic vascular resistance was 2300. Okay, so that's my case study. We'll come back to it. Super nice lady, by the way. Kind of crazy, but they are all crazy. So anyway, anatomically, the heart is one piece, has 4 chambers, and they function at the same time. We've learned that these chambers contract at the same time, uppers and lowers. They have these lovely sounds. However, though, I want you to put everything you know about the heart and heart function, and think of it, from now on, think of it as a physiological function of the heart. So, the heart has 2 sides. This will be the right side of the heart, and it has tubes that connects to the lungs, and it has tubes that connect to the left side of the heart, and at the same time they have tubes that connect to the system. From now on, I want you to picture the heart this way. The right side does not talk to the left, and the body has nothing to do with the lungs, okay? The blood in the system will always flow this way, okay? And the pressure in the system will grow this way. With that being said, the pressure here will be greater than the pressure here. And I want to introduce two terms for you. The pressure in the system we're going to call systemic vascular resistance. A normal systemic vascular resistance is between 800 and 1300, okay? Keep in mind, the one in La lady was 2300. And the pressure here we're going to call pulmonary vascular resistance. It's way less, and I'll tell you the value later. I don't want to confuse you. Okay, so this is how the heart works, okay? This side talked to this side to this one, and this one to this one. When the pressure increases, it will affect the one to the left, to the right, okay? So pressure increases from left to right, and blood flows from right to left. So, a little example for you to understand this is to think about heart failure. When you have a patient in heart failure that has left ventricular failure, the pressure will increase in the lungs, from the left side to the lungs. And this will cause a backup of fluid in the lungs, which will lead to the famous and infamous pulmonary cardiogenic edema, okay? Now, if we have an increase of pressure or a left or a right ventricular failure, that will lead to edema peripherally and JVD, okay? Again, JVD is not always a fluid overload situation. In this case, it's an obstructive issue, okay? So, moving forward. This is simple. If this is affected, it will affect this. If this is affected, it will affect this. And if this is affected, it will affect this. So, let's take this one step further. We are going to start with, that does not work. So we have, this will be the right atrium. This will be the right ventricle, the lungs, left ventricle, left atrium, left ventricle, and little Carlito on that side, okay? That will be the system. So this is how pressure really works. Now, what do I mean? When we are able to insert a pulmonary catheter, we come in on our normal heart. The heart looks like this, and the heart receives blood from 3 places. Most of us always forget the third place. So it gets from the ascending vena cava, descending vena cava, and the coronary sulcus. The coronary sulcus is that little vein behind the heart that collects all the blood from the coronary vessels and dumps it into the right atrium. So the blood gets right here. So from here, we have the tricuspid valve, right ventricle, and the pulmonary valve. The pulmonary valve is right here, which connects to the pulmonary artery, right? So when we use the Swan cath, we bring it here, insert it right there, move to the ventricle, move up, and we always leave it here. Usually, if you see any image of the heart, the catheter will be always on the left side, on the left branch. So this catheter, like you can see here, does not reach the left side, okay? It stops in the pulmonary artery right here.
Your attention, please. Visiting hours have ended for the evening and will resume at 9 a.m. tomorrow. We appreciate your understanding. Please exit the hospital at this time. Thank you for
Worst
visiting.